Okay, thanks.
So, in 2017, the American Heart Association actually changed the definition of chronic hypertension. They decided that any blood pressure less than 120 over less than 80 was actually normal. An elevated blood pressure was considered 120 to 129 over anything less than 80. And stage 1 hypertension is 130 to 139 over 80 to 89. And stage 2 hypertension is 140 or greater than 140 or 90. The big difference in their definition and how they manage hypertension is that now in stage 1, they treat people who have cardiovascular risk factors. We thus far don't know what the outcomes will be, but the hope is that treatment early on patients with multiple risk factors for heart disease, such as hypertension, diabetes, obesity, and high cholesterol, that if we treat them earlier, then they will do better long term. Next slide. Now, chronic hypertension, we used to say 90% or was essential hypertension, which means that it is just just a disorder that's not related to anything else. And I always say in South Carolina, if you don't have a family history of hypertension and diabetes, that you were not born in this state. You were an immigrant in. Because it is true, nearly every South Carolina family has a history of chronic hypertension. Now, there are secondary causes of chronic hypertension, such as medications. Birth control pills, for example, can cause chronic hypertension, and that's why we follow up at-risk patients once we put them on the pill. Of course, illicit drugs like cocaine and amphetamines, and then there are things like pheochromocytoma, which we all look for our entire career and never find one, primary aldosteronism, Cushing's disease, and hyperthyroidism, just to name a few. Now, who should we work up for secondary hypertension? And this is in the non-pregnant state as well as in the early pregnant state when we first see patients. That is, if we have patients, we need to look at their medicines. For example, SSRIs can cause hypertension, and if somebody's just gone on that, we need to look at that. And the hypertension in secondary hypertension is usually an unusual presentation. You know, the person is 5'2", weighs 120 pounds, and has a drug-resistant hypertension, meaning that one drug will not control the blood pressure, and often 2 to 3 drugs are needed. And there are also clinical clues, such as an abdominal bruit will identify renal artery fibrodysplasia, which we used to think of as renal artery stenosis. You can hear bruits sometimes associated with them. Another clinical clue is like low potassium. low potassium is associated with primary aldosteronism, and so you should immediately think of that if you get back a chemistry panel with significantly low potassium. And I'll be honest with you, if I'm worried about secondary hypertension, I refer these individuals to internal medicine to get their opinion, and I do not work these individuals up. Next slide. So this is one issue in pregnancy, and it has been an issue for years and years and years. OBGYNs do not use the same definitions as internists do for chronic hypertension. And therefore, we are going to see more and more individuals labeled as chronic hypertension in pregnancy when their blood pressure is only 130 over 139. Okay? And so we all need to prepare for that. Now, we define hypertension as elevated blood pressure prior to conception. If you're treated for high blood pressure before you conceive, you got hypertension. Or if you come in at less than 20 weeks and have blood pressures greater than 140 over 90, at least 2 times, and they need to be 4 hours apart. There has been significant controversy as to what to call severe range blood pressure in pregnancy, and the last ACOG bulletin basically said we need to stick with what is in the literature and what we have always done, and that is greater than 160 over 110. The Hypertensive Task Force actually had internist on it, and the internists were adamant that we need to lower 110 to 105 for the patient's safety, and they were adamant about us lowering 160 to 150 and treating patients who are greater than 150 over 105. This caused significant amount of confusion, so ACOG wrote a message in 2019 saying we should all go back to considering severe range blood pressure at 160 over 100. Next slide. So the treatment in pregnancy, we usually don't recommend it until the patient gets severe range blood pressure. And I'm not talking about preeclampsia, I'm talking about straightforward hypertension. And so if their blood pressure is greater than 160 over 110, then we recommend treatment. So it is recommended that we do earlier treatment in individuals like with organ damage. For example, if an individual has had renal insufficiency, then we should treat them at 140 to 150 over 80 to 90 to 100 instead of waiting to greater than 160 over 110. There was a CHIPS trial, which was a randomized trial. It was in an international trial that looked at tight control of blood pressure versus less tight control of blood pressure. The tight control group had a systolic blood pressure of less than 85 millimeters of mercury compared to 100 millimeters of mercury for the less tight control. And there was actually no benefit for the fetus at all, and there was no detriment to the fetus either. In other words, tighter control did not increase the outcomes of IUGR, for example. Now, for the mother, there was a benefit. Now, it did not reduce things like preeclampsia or anything that you would like it to. The only thing that it reduced was the treatment for severe maternal hypertension. Next paragraph, or next. So this slide shows us the medications that we use. It is highly recommended that we use one medicine and then max out on that medicine and then add a second medicine if you do not get good control. Okay? We shouldn't just give somebody labetalol 200 milligrams twice a day and then add nifedipine to it. Because if we have patients with one drug, they're more likely to be compliant. So labetalol, the maximum dose is actually 800 milligrams TID. And it's usually started at 100 milligrams twice a day or 200 milligrams twice a day. If I have patients that I start at 200 milligrams twice a day, then I will, depending on how their blood pressure looks, I will either increase their medicine, like double it to 400 milligrams twice a day, or simply increase them to 3 times a day. Now, if you give labetalol in a non-pregnant state, people know that it is a 2 times a day drug. And the reason that it changes in pregnancy is because the metabolism of pregnancy or the changes during pregnancy alters the metabolism of labetalol. So labetalol can cause a bronchoconstrictive effects, and it should be avoided in people who have asthma, pre-existing myocardial disease, or decompensated cardiac function, a heart block, or bradycardia. Now, nifedipine is a once-a-day drug that we usually start off at 30 milligrams a day, and if it's not working, we immediately go to 60 milligrams a day. Nifedipine's a very nice drug since it's a once-a-day drug, but it's very important to do not use the sublingual form. Sublingual nifedipine, it can actually drop the blood pressure so rapidly that it can cause a stroke in the individual. So please do not use that. And there are immediate release formulations of nifedipine, but they are usually given on an inpatient setting instead of an outpatient setting. Methyl-dopa is actually another drug that when I was coming through residency and fellowship, we almost always started with this drug, 500 milligrams, 2 to 4 times a day. And the safety data, we have more safety data on this medication than we do any other medication for hypertension. And we followed Offspring up to 7 years, and there's no problem with it. The issue is that it is sedating. It makes patients sleepy. It can make them dizzy and depressed. So it shouldn't really be used in patients with severe depression. I I used to use this all the time as a first-line drug, but I can't tell you the last time I actually prescribed this drug, because nifedipine and labetalol are much more commonly used. I do want to back up and tell you that nifedipine can cause tachycardia, but the other thing nifedipine does is it can cause a headache. And so when you were treating patients with chronic hypertension on the outpatient and their blood pressures look good, but they keep saying, "Doctor, doctor, I have this bad headache. I have this bad headache." And I always ask them, did it start when I initiated the medication? Because again, nifedipine can cause headaches. Now, there are a lot of second line and third line drugs like clonidine, hydrochlorothiazide, um, there's an array of second line and third line treatments. If I am treating an individual and I am out of nifedipine and labetalol, I basically consult medicine to help me to see if there is what they would recommend to us. In the past, we have avoided diuretics, and the reason that we've avoided diuretics is because we do not want the patient to be intravascular deplete, because we think that that's associated with a higher incidence of preeclampsia. Next slide. There are two drugs, ACE inhibitors and ARBs, that we recommend stopping immediately in the first trimester when individuals find out that they're pregnant. Now, if you probably about 7 or 8 years ago, there was a study out of Tennessee that looked at birth records and outcomes, and they came back and said that there was a higher incidence of fetal heart defects with ACE inhibitors, and multiple places have looked at this, and some of them have said they agree with Tennessee, but in countries with the best medical records like Sweden, population-based studies have not shown this to be true. The CNS lesions are also controversial. They have looked, like neural tube defects, a couple of neural tube defects, or a dandy walker, which when you read the study, I really have a hard time believing that an ACE or an ARB would cause that. But again, this is controversial, and I do give the patients my opinion in this. I tell them it's controversial, but if there is an increase in fetal cardiac defects, it is only very slightly. Because fetal heart defects is the most common defect in our population. Now, ACE and ARBs, there's no doubt about it that in the second trimester, it causes dysplasia of the renal filtering apparatus, the glomerulus, and this is an irreversible damage that is done to the kidney. So individuals can take it in the first trimester and it does not bother their kidneys, but if they continue it in the second and third trimester, then you need to counsel them that it can cause renal damage. I would get an ultrasound, and you can't measure the kidneys or look at the kidneys to see if there's any damage, but what you can follow is the amniotic fluid index to see if it stays normal in the second and third trimester. Next slide. And the beta blockers, you see propranolol, labetalol. I saw one yesterday, bisystolic. that I had never seen before. But we see a toprolol. We see a lot of different beta blockers. And atenolol is the only one that we should avoid during pregnancy. And the reason we should avoid that one is it's reported to be associated with a higher incidence of IUGR. Um, the biggest question I get from my residents is, Dr. Johnson, she has hypertension. Should I get baseline preeclamptic labs? Well, that kind of drives me a little crazy. And the patient shouldn't have anything wrong with her liver, okay, if she is just a hypertensive. So the labs that I recommend, and it's recommended by ACOG, is a PC ratio. The only time I do not recommend a PC ratio is when individuals have significant proteinuria. I do get a 24-hour urine so that I can look at their creatinine clearance as well as the amount of protein. Because in pregnancy, the amount of protein normally goes up, but the creatinine clearance goes up too. And so I look at to see if the creatinine clearance is going up with with protein or down with the protein. And if it's going down and the protein is increasing, then I worry more about preeclampsia. Obviously, you also need to look at a serum creatinine. I usually get a BMP on these individuals just so I can look at that, and I don't order just a creatinine. So, who should you get an EKG or an echo on? And the individuals that require EKG or echo are people with long-standing hypertension. 4 to 5 years, and they have had significant hypertension requiring treatment. And anybody who has severe hypertension on 2 or more drugs deserves an EKG or an echo. The reason that we look at an echo is because a lot of individuals actually develop cardiac dysfunction, like diastolic dysfunction, when they are have severe or long-standing hypertension. And basically, that is the end of my talk, but I